I'm Joe Graydon.
I'm Terry Graydon. The People's Pharmacy podcast is brought to you in part by Squatty Potty, the original toilet step stool that creates healthy toilet posture. Learn how squatting relaxes the colon and allows for easy, healthy elimination at squattypotty.com.
And by Comfy, makers of all-natural buckwheat hull pillows. Comfy pillows provide superior support by conforming to your head and neck for healthy, restful sleep. On the web at comfycomfy.com. For 10% off your first order, enter the code PEOPLES at checkout. How bad is bacon? We've been told that processed meat causes cancer. Is there any way to determine the degree of risk? This is the People's Pharmacy with Terry and Joe Graydon.
Americans love pills. People are taking more medicine today than ever before. In the last decade, the number of people taking at least 5 different medications has almost doubled. Are you swallowing a handful of pills every day? Are they compatible?
A new study in the New England Journal of Medicine shows that there are advantages to getting systolic blood pressure below 120. What are the drawbacks?
Coming up on the People's Pharmacy, the health news that matters to you with your calls and questions.
First, this news.
In the People's Pharmacy Health headlines, a large study of blood pressure treatment was stopped early in September because the results were considered so promising. Now, the data have been published in the New England Journal of Medicine. The study was called SPRINT, which stands for Systolic Blood Pressure Intervention Trial. 9,361 people with hypertension were recruited to participate. Half were randomly assigned to get their systolic blood pressure below 120. The other half were treated to get systolic blood pressure under 140. Those in the intensive treatment group were 25% less likely to experience a heart attack or other cardiovascular event. In absolute terms, 1.65% of those in the intensive treatment group suffered such an outcome, compared to 2.19% in the standard treatment group. Intensive treatment resulted in more side effects, such as low blood pressure, fainting, kidney problems, or electrolyte imbalance. While the investigators were justifiably proud of the benefits of intensive blood pressure control, they point out that 172 people needed to get their systolic blood pressure under 120 to prevent one death from cardiovascular causes in 3 years.
Angioplasty, to place a stent or several stents in coronary arteries, is known medically as percutaneous coronary intervention, or PCI. It's used to open blocked coronary arteries and treat chest pain due to angina. Doctors did not know for sure whether or not it would help people live longer. Now, long-term results show no difference in survival between people randomly assigned to get drug treatment or PCI for their angina. The study included more than 2,000 people with stable heart disease who were followed up for as long as 15 years. There were 284 deaths in the group that got PCI and 277 in the group getting medical therapy. That's not a statistically significant difference. The researchers point out that these data are consistent with those from several previous trials. Until data show an advantage to angioplasty and stents for angina, it may make more sense to treat this heart condition with medication.
Epidemiologists have found a link between a meat-rich diet and kidney cancer. They surmise that the carcinogens formed when meat is exposed to high heat or open flame are responsible for the significantly higher chance of developing renal cell carcinoma. The kidneys work to remove toxic substances from the bloodstream and so may be exposed to higher levels. The researchers, based at MD Anderson Cancer Center, found that people with a specific variant in the ITPR2 gene were especially susceptible to the danger of charred meat. People with this genetic variant might do well to cut back on meat cooked at high temperatures.
A small study just presented at the American College of Rheumatology meeting shows that the dietary supplement chondroitin sulfate is about as effective as the drug celecoxib in alleviating the pain and stiffness of knee osteoarthritis. The high-quality chondroitin used in the study slowed the deterioration of the knee joint more effectively than celecoxib over the course of the 2-year study. The researchers used MRI scans to assess the condition of the joints. The principal investigator concluded that chondroitin, in contrast to celecoxib, can reduce the loss of cartilage, at least in part, by reducing synovial inflammation.
A study from Tufts University in Boston has found that Tai Chi works just as well as physical therapy to ease pain and improve function for people with osteoarthritis of the knee. In the study, approximately 200 volunteers were randomly assigned to physical therapy or Tai Chi classes. Those in the Tai Chi group did 2 classes a week for 12 weeks to learn classical Yang-style Tai Chi. Those in the physical therapy group had sessions twice a week for 6 weeks and practiced the exercises at home for an additional 6 weeks. The scientists used WOMAC scores, a standardized arthritis symptom questionnaire, to assess progress and found that both groups had improved by the end of 12 weeks. Both groups had also reduced the amount of pain medication they took. The group practicing Tai Chi also reported lower depression scores, and the researchers recommend that Tai Chi be considered as a therapeutic option for treating knee osteoarthritis. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon. I'm a medical anthropologist.
And I'm Joe Graydon. I'm a pharmacologist. Last week, we were told that processed and red meat can cause cancer. This week, we're told that eating meat cooked at high heat leads to kidney cancer. How good is the science behind the headlines?
Later in the hour, we'll discuss the SPRINT blood pressure study and get the details that were published this week. Should you try to get your systolic blood pressure under 120?
We'll also discuss the fact that we Americans are taking more medicines than ever. Does that mean more side effects and drug interactions? First, though, how bad is bacon?
And we'd like to hear from you. What was your reaction to the news about bacon, ham, and hot dogs? The number to call to join the conversation is 888-472-3366. You can also send us an email, radio@peoplespharmacy.com, or reach us by way of Twitter. We're at People's Pharmacy. To join the conversation again, give us a call, 888-472-3366.
To find out more about the questions of carcinogens as well as the problem of risk, we spoke with pharmacologist Dr. David Kroll. He's also a health journalist. As a scientist, he did research aimed at discovering anti-cancer compounds from natural sources, and he's an expert on botanical medicines. He's a graduate advisory board member of the Master's Program in Science and Medical Journalism at the University of North Carolina at Chapel Hill.
Welcome to the People's Pharmacy, Dr. David Kroll.
Pleasure to be here, folks.
Thank you for joining us. Dr. Kroll, the International Agency for Research on Cancer, the IARC, as they're referred to, has initiated a big announcement that made headlines all across the world. Watch out for processed meat. Red meat, you're in trouble, increases the risk of cancer. And now we're talking about bacon, sausages, hot dogs, ham, salami, and forget the pepperoni on your pizza. What's the story?
Yeah, this is not good, and I'm extremely disturbed. But in all seriousness, what the IARC did, they're a group of scientists that are convened by the World Health Organization to examine studies that have been published about particular chemicals, even lifestyles and occupations, and what the quality of evidence is regarding whether these things can cause cancer. And what they do is they classify these items based just on the quality of the evidence, not the percentage increase in your risk of getting cancer from these things or any consideration of the dose of these things.
So Joe just mentioned red meat and processed meat in the same breath, in the same sentence, but the IARC doesn't put them in the same category, do they?
No, they don't. They keep red meat is apparently safer than processed meats like bacon. And so the idea here is that they put beef, lamb, and even pork in the category of red meat. And processed meats, things that are taken from their sort of natural state and pieced together or smoked or preserved or cured, as most bacon is in a separate category that carries a greater probability of cancer risk.
Now, we have heard that there are problems with processed meat for quite a while. I mean, there have been a lot of studies, and there have been a lot of hypotheses. What the problem is that the preservatives, for example, the nitrates, the nitrites, is it other chemicals that they're putting in there? Is it the coloring agents? So do we have any sense what the actual risk may be besides there is a risk?
Well, we do know from the studies that the IARC looked at that the risk of getting colon cancer, for example, by eating 50 grams of bacon a day, which is about 2 ounces, a little shy of 2 ounces, increases by 17 or 18%.
So is that what, 2 slices of bacon?
2 slices of bacon, 2 to 3 slices of bacon. So I think to answer your question, Joe, I would say most evidence points to the nitrite and nitrate preservatives that are in processed meat that give those the added risk. And we've known for a long time that nitrates and nitrites increase the risk of cancer.
Presumably because that leads to the formation of nitrosamines by gut bacteria, and that leads to carcinogenicity.
Exactly. And then there are also things that are present in these meats that also interact with the nitrate in our saliva, turns out, to create these nitrosamines as well. So that is the biggest concern with cured or otherwise processed
Now,
meats.
I have to admit that I have become somewhat of a vegetarian. I do eat fish occasionally, but there are a lot of people who are saying, I can't give up my bacon. I can't give up my pepperoni pizza. How big a risk is this if I have bacon once or twice a month? And that's where people really are getting confused, because it sounds like, wow, 19% risk, colon cancer.
But that's if you eat it every day. And there doesn't appear to be an assessment of risk with this classification, is there?
No, that's what's really disappointing and honestly confusing to the average person. Even many scientists don't quite understand what this classification is about. And what we really know is that there is a very clear linkage between processed meat and increased risk of colon cancer. But you're right, Terry, what that increased risk is extremely small. There is a 17 or 18% increase in relative risk, which is the percent increase over what is the normal risk. But the actual risk, what people call the absolute risk, increases extremely small. In fact, if you look in England, for example, rate of colon cancer is about 55 people in every 1,000, lifetime risk. Eating 50 grams of bacon a day goes from 55 to 65 per 1,000. So an extra 10 people per 1,000, or an increased absolute risk of 0.1% is what one incurs by eating bacon every day. And I don't think that most people eat bacon every day.
So this really opens the can of worms of relative risk or relative benefit versus absolute risk or absolute benefit. And I remember several years ago when the statin ads were out there, in particular Lipitor, and it said you can lower your risk of having a heart attack by 30% or more by taking Lipitor. And yet when you actually looked at the study, it meant that 3 people out of 100 who didn't take a statin had a heart attack. 2 people out of 100 who took Lipitor had a heart attack. 1 out of 100 benefited. But that's a 30% relative risk improvement. So how can people make sense out of this relative versus absolute risk?
Well, I think the biggest question is to look very closely at the media reports and how that information is represented. You'll find that some news outlets are better than others and explicitly will say the absolute risk being this, the relative risk being that. The problem, of course, is that because relative risk looks like a bigger number, that tends to be what the press will most often cite. And this is where I have to hand it to you folks, because you really look closely at all these data and represent them to your listeners in the real world sense of what the actual increased risk is and the actual increased benefit is.
Dr. Kroll, I wonder if you can help us understand what we should take away from the IARC pronouncement. Should we be making changes in the way we eat?
Well, I think listeners across the board should know that when the IARC makes these pronouncements, they are in the context of whether the quality of data on the increased risk is strong or not. It doesn't go into what the actual risk is. The increased risk from eating processed meats every day for causing colon cancer is extremely small when it comes down to it. But what we want to do in our entire lifestyle is decrease our risk of getting cancer, decrease our risk of getting high blood pressure. You don't have to completely quit bacon, okay? I think that's an important point. But you can certainly cut down on the amounts of processed meats and bacon as part of your overall approach to your personal health to minimize your risk of cancer and heart disease.
You're listening to Dr. David Kroll. He is a pharmacologist and health journalist. He's an expert on botanical medicines, and he writes for Forbes.com.
We'd love to hear from you. Will you be changing your diet, or have you already changed? Will you give up bacon? The number to call to join the conversation is 888-472-3366. You can reach us via Twitter at People's Pharmacy. Again, the phone number is 888-472-3366.
And when it comes to risk, Joe, that risk is the absolute risk really is quite small. Dr. Kroll was saying that it's 10 per thousand. That actually comes out to a 1% rather than 0.1%. But one of the studies that the IARC based its decision on was the EPIC study, which found that people in the highest risk category had a 10-year risk of colorectal cancer of 1.71%. That's over 10 years. And those in the lowest category, 1.28%. So not a big spread between those two.
Now, we were also told this week, Terry, that grilling, especially, high heat, will increase your risk of kidney cancer. So there are a lot of people who are going, but I love to grill. We have a couple of quick tips, don't we?
We do have some tips, and you can find a link to them from our website. One tip, first, trim away the fat on the meat, any visible fat. Marinate your meat before you grill it. And using in the marinade yogurt or lemon juice, extra virgin olive oil, vinegar, rosemary, garlic, or onions, any of those can be helpful in reducing the carcinogenic compounds that can form. Microwave just a little bit before you grill or broil, and then throw out the juice that is left over. And then lower the heat, or flip your burgers or chicken breasts frequently.
Because anything you can do to reduce the amount of heat will also reduce the number of carcinogens. So there are some tips, and you will find them at peoplespharmacy.com. We need to take a short break, but when we come back, we'll talk more about meat, and we'll continue our conversation with pharmacologist David Kroll. A new study suggests that Americans are taking more medicines than ever.
Does polypharmacy increase the risk of drug interactions?
You can join the conversation, 888-472-3366.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible by Red X Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. The number's 800-345-7339. The website, uttercream.com.
And by Squatty Potty, the original toilet footstool that creates healthy toilet posture. You can learn how squatting relaxes the colon and allows for easier, healthier elimination at squattypotty.com.
If you'd like to purchase a CD of this show, you can call 800-732-2334. Today's show is number 1013, or find it on the web at peoplespharmacy.com.
Today, we're talking about the health news that matters to you. We've been discussing the danger of meat, especially processed meat or charbroiled meat, in raising the risk of cancer.
We turn now to the issue of medications. Have you been watching television lately? If so, you cannot avoid prescription drug commercials, whether it's Viagra and Cialis for ED, erectile dysfunction. You're probably seeing a new commercial for Opdivo for lung cancer. It shows a cityscape and this big message. It's projected on the walls of the buildings. Then there's Praluent, a brand new drug to lower cholesterol, or Jublia for nail fungus.
That cartoon toe is playing games.
Yes, the toe is either playing tennis, boxing, or now playing football. It seems if you're paying attention to those TV commercials, there is a pill for every ill.
Well, maybe that's why more Americans than ever are taking medicine. What are the consequences? We discussed this problem with pharmacologist and journalist Dr. David Kroll.
Dr. Kroll, JAMA, what used to be known as the Journal of the American Medical Association, had a really interesting article a week or two ago about what is, I guess, called polypharmacy and how common it has become. First of all, what do we mean when we say polypharmacy?
Well, polypharmacy is a pharmacy term that describes the practice of patients being given more than one drug. Predominantly in pharmacy schools, you'll hear it as more than 5 drugs. And so this is very common for a lot of folks, predominantly older folks that have a variety of issues.
In fact, this article seems to show that we're just taking a lot more medicines across the board.
Yeah, I think what the JAMA article has shown is that back in 1999-2000, 50% of the population took at least one prescription drug. And what we've seen in the most recent numbers, 2011-2012, is that's increased from 50% to 60%.
So most of us are taking medicine.
More than half of us are taking medicine. Not a surprise.
And what's really scary about this JAMA article is that in that decade that you're talking about, the change in polypharmacy has been dramatic.
Yeah, and I think that's really the biggest concern in this paper is we have gone from 8% of folks taking 5 or more drugs 10 years ago now to almost double that, 15% taking 5 or more drugs.
Why is that a problem?
Well, every time you add a drug to a patient's sort of cluster of medicines, you increase the risk also of side effects. And those combinations and permutations, every time you add one, could increase the risk of side effects twofold, fourfold, however many you add to that. That
so we refer to this as drug interactions, where 1 + 1 in some cases might equal 3. That is to say, an exaggerated effect, more sedation. Sometimes 1 + 1 equals 0 because one drug cancels out the benefits of the other
Exactly,
drug.
like drinking milk with tetracycline.
Yeah, drug won't work. The antibiotic won't do what it needs to do. And if you're taking something for Rocky Mountain spotted fever, that could be a life-threatening situation if your antibiotic doesn't work. Right. So I thought this was like a thing of the past, that drug interactions, that bad combinations in the old days when doctors actually had to go to books to look this sort of thing up because they can't keep it all in their head, that was a problem. But today we've got smartphones, we've got computers, we've got computers that can check on every possible permutation and combination. Why do we still have a problem?
Well, Joe, that's interesting. You say that we have these computer systems, and certainly I would say at the level of your pharmacy, your community pharmacy or your mail order pharmacy, if you're getting all your drugs from the same source, chances are they will pick up some of these side effects. But most people don't get their drugs all from one source, nor do they get all their drugs from one prescriber. And unless a physician has access to the drugs that other doctors are prescribing for you, they won't know if the drug is going to have an interaction unless you're a really good patient and you bring your drug list every time you go to the doctor.
And we definitely recommend that people do that. Write it down or print it out. Make sure you tuck it into your wallet so you have it whenever you might need it, and keep it up to date.
But there is a problem. The problem is the following. So you only go to one pharmacy, and that pharmacist knows everything you're taking, and a new prescription arrives, and that new prescription comes up on the computer as a potential problem. Now, you're waiting to get your prescription filled, and the pharmacist is there trying to accommodate you, but there's a problem. The computer says, this isn't good. So the pharmacist calls the doctor's office, but the doctor's seeing a patient now. The doctor can't come to the phone. Well, now what happens? You probably, if you're a pharmacist, you're going to send the patient home, and the doctor may or may not return your call by 5 o'clock that evening. He or she may or may not return the call the next day or the following day. And so meanwhile, the patient is waiting for the medicine. So this sets up a real complicated communication situation.
Right. I mean, does the pharmacist fill the prescription that has a known risk of drug interaction? The doctor wrote for it, of course. Or do they withhold the drug because of the risk of the interaction? And say if it's an antibiotic, the patient goes, a day or two without getting the antibiotic when treating it as quickly as possible is the better thing. I agree it's a huge problem, and probably is the problem with us not having sort of a centralized electronic medical record system as a nation.
Well, what we hear from doctors who are trying to use these electronic medical records is that even though the idea is great, that you'd be able to see everything, in practice, they're really hard to use, and they do more obscuring than helping.
Yeah, and that's a lot of times it's because different systems don't
talk
to one another.
Each other.
The time it takes to input the information is it's just a tremendous sort of hurdle to get over.
And there's the cry wolf problem. There are so many warnings and alerts that come up on the computer that after a while, sometimes doctors and pharmacists override the alerts because they wouldn't prescribe anything or dispense anything if they followed every single alert.
And of course, that can be a problem if a drug interaction has been flagged as a potential and the doctor or the pharmacist has given out those two drugs together before, and the patients who got them didn't have a problem, but one patient is a little bit different and may be metabolizing a drug a little bit differently and can have a disastrous interaction.
Right. Everybody has a different rate of metabolizing these drugs. And I think another issue that the pharmacist and the physician may not know is that the patient may be taking over-the-counter drug that's not listed in that system. And we have to remember that over-the-counter drugs are medicines capable of benefit and of side effects.
So what is the take-home message, Dr. David Kroll, when it comes to polypharmacy?
The take-home message is to really talk seriously with your doctor and ask he or she, do I really need to be on all of these drugs? Even if it's not the drugs that just that physician's prescribed, bring your whole list and really take a good amount of time in that visit and look at those drugs. We are really good in medicine about adding drugs to patients. We're not very good about discontinuing drugs that are no longer needed.
Thank you so much for sharing that with the People's Pharmacy listeners today.
My pleasure.
You've been listening to Dr. David Kroll, a pharmacologist and health journalist. His research has focused on the discovery of anti-cancer compounds from natural sources. He is an expert on botanical medicines. He is a graduate advisory board member for the master's program in science and medical journalism at the University of North Carolina at Chapel Hill.
And if you have a question or a story to share about drug interactions, please give us a call. 888-472-3366. Our email is radio@peoplespharmacy.com. And you can send us a message through Twitter. We're @peoplespharmacy. Again, that number, 888-472-3366.
And you know something, Terry? It's really interesting that I think a lot of people think, well, it's all theoretical. You know, this doesn't really matter all that much. If I take a bunch of vitamins and minerals and Aleve, and I take some herbs and dietary supplements along with my prescription meds, you know, nothing bad could happen. Well,
I have a feeling you're about to tell me what terrible thing did happen to somebody.
Well, what happened in Canada is they actually looked at this. So they were looking at drugs that are taken for high blood pressure. So we're talking about ACE inhibitors or something called ARBs. These all belong to a category called RAS, R-A-S, renin-angiotensin system inhibitors. So what are the drugs? Well, lisinopril, ramipril, losartan, valsartan used to be sold under the name Diovan. If people were taking that category of blood pressure drugs and then they got an infection, maybe a urinary tract infection or sinusitis, and somebody decided they were going to prescribe a kind of medicine called cotrimoxazole. Now, that used to be sold under the brand names Bactrim or Septra. People will remember them. They're also sold under an abbreviation, different kind of name called
SMZ-TMP.
Right. Trimethoxazole, sulfamethoxazole, trimethoprim combination. Well, sudden death was the consequence.
That's a very bad outcome.
A lot of people developed very high levels of potassium, and their heart stopped. And what they said at the end was they noted that such deaths would probably be blamed on underlying heart disease rather than a drug interaction. So the only point I'm making here is drug interactions can be lethal.
They make a big difference. Let's go to the phones. We go to Dr. Charles in Ahoskie, North Carolina. Dr. Charles, welcome to the People's Pharmacy.
Hi, Joe. Hi.
Hi, Dr. Charles. What's up?
Hi. I want to point out that as a primary care physician, we're in a situation now where we're being encouraged to identify more problems that, once identified, of course, need treatment by the doctor. And we have a new coding system called the ICD-10 coding system. And so it forces us to identify more problems, and therefore we're more likely to prescribe a medication to solve that problem. And we're being pushed into polypharmacy in part by identifying more problems. And from a financial point of view, speaking frankly, that you can, once you identify more problems and you make decisions about all these problems, you can code at a higher level, and therefore you get a higher level of reimbursement for your visit.
So there's an
we're being pushed we're being pushed basically to prescribe more medications.
Can you give us an example, Dr. Charles?
Well, I saw a gentleman the other day who came in for a simple problem that related to his musculature, and it turned out that as I was talking to him, the number of problems that I generated in the visit was like 5 or 6 just by listening to him and extrapolating off of his commentary. And if I would have followed up on all those problems that I identified, including on physical exam, seeing that he had calcification of his eardrums, and I asked him about his hearing, and he had decreased hearing, etc., I would have been very easily led to to blast him with all sorts of interventions that really he didn't come in for.
Now, Dr. Charles, I've got a question for you, because if you watch any television at all, you, like the rest of us, are seeing commercials for not just Viagra and Cialis, but as I mentioned, now you will see commercials for very potent drugs for like lung cancer, Opdivo, and Humira for rheumatoid arthritis, and the list goes on, so that I think one thing that may be driving all of our polypharmacy is that people are seeing these commercials and calling their doctor and saying, well, they told me that I should ask my doctor if drug X is right for me.
Well, I tell you, I practice in such a poor environment, and the cost of medicines is going up so much that the pressure from patients to put them on a drug is actually really counter pressure to, I can't afford that drug. My population is about 30% uninsured or very poorly insured with a lot of copays. So there is that counter pressure going on. And in my area, I get a lot of pressure to control diabetes, of course, and something like Victoza, GLP-1 agonist, is something that I would really like to prescribe. But the problem is that almost nobody can afford it. Even physicians can't afford the $600 or $700 a month if you don't have full coverage.
Dr. Charles, thanks so much for calling.
Pressure going up on that really is not being generated in my area, Hosky, North Carolina, northeastern North Carolina, a very poor area. And so there is that situation. But if I, as a physician, identify a problem, that I'm encouraged to be doing now, I'm more likely to say, well, how about doing this or that? Although I oftentimes first suggest home remedies like the vinegar and Listerine that's been on this program.
We are always in favor of that. And that's affordable for almost anyone.
Right. White vinegar, you can buy a gallon very inexpensively. And it's so interesting you mentioned that regarding the nail fungus. We did some analysis on Jublia, and Terry, it's pricey.
It's very pricey. And you get just a tiny little bit. You have to get a lot of refills because it takes a long time. Anytime you treat nail fungus, it takes a long time. It takes a long time to treat your nail fungus with vinegar and Listerine.
Right. But 10 months later, what is the success rate with Jublia?
Somewhere between 15 and 18%.
For a complete cure. So you might have to spend hundreds, maybe thousands of dollars, and people might want a home remedy instead.
They might. Joe, we do have an email from someone who wants to know if there's any drug interaction software or any place people can go on the web to discover if their drugs interact.
Well, there are lots of drug interaction checkers for sure, and it's worth doing.
Yeah, and Hippocrates is one of them.
Hippocrates is great. We need to take a short break. When we come back, we're going to talk about blood pressure. How low should you go? If you'd like to join the conversation, our number, 888-472-3366. Email us, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website? Well, you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redx Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty, the original toilet footstool that creates healthy toilet posture. You can learn how squatting relaxes the colon and allows for easier, healthier elimination at squattypotty.com.
If you'd like to purchase a CD of this show, you can call 800-732-2334. Today's show, number 1013, or you can find it online at peoplespharmacy.com.
We're exploring the stories behind the health headlines today. A month or so ago, an important new study of blood pressure control was stopped early because the results were so impressive. Now those results have been published, so we'll have a closer look.
If you have a question or a story to share about lowering blood pressure with or without medication, you can give us a call. The number is 888-472-3366. You can email us, radio@peoplespharmacy.com, or via Twitter @peoplespharmacy. Again, our number, 888-472-3366. Now, Terry, SPRINT, what does that stand for? Systolic Blood Pressure Intervention Trial.
Right, and what they did was they had a whole lot of people, more than 9,000, and these people were very carefully selected, and they randomly assigned them either to get their usual care that would bring their blood pressure, their systolic, that's the higher number, to 140 or under. And the other people had to take enough medication to get their systolic blood pressure to 120 or under.
And the results, please?
Well, they actually stopped, as you mentioned, they stopped the study early because people were 25% less likely to experience a heart attack or a stroke or anything of that sort, or to die of a cardiovascular cause if their blood pressure was lower. Now, that's relative risk. So the absolute risk, 1.65% of those in the intensive treatment group suffered a cardiovascular problem.
In other words, under 120.
Yeah. And the ones that were under 140, 2.19% of those suffered such a problem.
So not as impressive when you look at the absolute risk reduction.
No, 25% relative risk sounds a lot more impressive.
Now, there's another way of looking at this, something called the NNT, the number needed to treat. And it turns out you would have to treat 172 people to get their blood pressure under 120 in order to prevent one death from cardiovascular causes after 3 years.
And there were some side effects. So people did develop low blood pressure, people who were being treated to get their blood pressure way down, did get their blood pressure sometimes down below what was desirable. Some of them fainted. They had electrolyte imbalances. You mentioned earlier that potassium going out of balance can be lethal. They also developed kidney problems more frequently. So that's something that needs to be balanced. And the other thing is, Joe, that the people in this study were very carefully selected. And
well, they were older people, so they didn't include anyone under 50. But Terry, blood pressure control does matter for people who are younger as well.
Absolutely. Absolutely. And to learn more about that research, we turn to Dr. João Lima. He is Professor of Medicine and Radiology and Director of Cardiovascular Imaging. He's also Professor of Medicine and Professor of Radiology and Radiological Science with a joint appointment in the Department of Epidemiology. That's all at Johns Hopkins Hospital. His research was published in the Journal of the American College of Cardiology.
Welcome to the People's Pharmacy, Dr. Lima.
Thank you. It's a pleasure to be here.
Dr. Lima, your research, published in the Journal of the American College of Cardiology, suggests that we all need to start paying attention to our blood pressure even before we get to the age of 50. Can you tell us a little bit about what your study found?
As a background, just a quick background, the cardio study was started in 1985 and was designed exactly to address these kinds of questions. That is, what should we do about the first period of adult life, say between ages 20 and ages 45. We know that during this period of time, most of us are healthy, but should we pay attention to exposure to risk factors at that time? Because we know that it's after the 50s and 60s that we start having clinical events or clinical disease events, and they don't, many of them have their beginnings way back when. And this is a study done along those lines to address the issue of how much attention should we pay to our own blood pressure during that period of time, during, ages 20 to 50, and does that have an importance on how well we are at midlife? That's basically what this research is about, that the 21st century has brought on by.
Dr. Lima, if I understand correctly, your study involved more than 5,000 people at the start of it, and you did measure their blood pressure as they went through the decades. I'm not sure how often you measured it, but then how often did you measure it, by the way?
It was measured an average of 7 times on each person.
Okay.
And as part of the cardio study, the cardio study entailed a series of examinations. And in the beginning, they were more frequent. They were every 2 years, but then they became like every 5 years. And as a matter of fact, we are in the process now of doing the year 30 examination. So cardio participants are coming to the 4 clinics in Oakland, Chicago, Minnesota, and Birmingham, Alabama for their year 30 exam. So this study remains
is still going on.
It's still going on. It's
Great.
very successful.
Now, I understand that you did some very sophisticated studying of how well the heart muscle is working, and we don't need to get into all the details about the technology on that, but what you found was that people who had higher blood pressure had not such great heart function after, 25 years. Is that right?
Correct. This is very important, and I'm glad you highlight the fact that the methods are somewhat technical, and I will go into it only if we feel necessary. But let's say that there are standard methods to measure how well the heart contracts, and basically we measure how much blood the heart beats with each beat in relation to how much it received. And if you take those indices that are the most commonly used, then you don't see much of a difference. But if you use more sophisticated technology, and that technology is based on measuring specifically how the heart is contracting in different regions of the heart, and then taking an average, and not only contracting but relaxing. The heart function is not only contraction and expelling blood or providing blood to the body, but it's also how fast it relaxes and accepts blood from coming from the rest of the body. So if we use these technologies, then we see that exposure to higher levels of blood pressure, even within the so-called normal range, that if you're on the top of that exposure, then your heart is not as strong by midlife. It's not as strong in contracting and expelling blood out of the main chamber, but it's also not as fast in accepting blood, in relaxing. What we find at midlife is a premonition of what is likely to happen later on, and with an increase in the risk for heart attacks and other cardiac problems, but specifically heart failure. There is a weakening of the muscle of the heart that leads to a very incapacitating situation later in life, but also an increased risk of stroke.
Dr. Lima, how high a blood pressure worries you for a person in his or her 30s or 40s?
I think a blood pressure that is higher than 140 over 90 is definitely very worrisome.
Dr. Lima, based on your research, do you have any advice for our listeners today?
Yes, I think I would try to keep the blood pressure. If I were between 20 and 45 years of age, to keep my blood pressure below 130 over 80. There is now a lot of discussion about keeping blood pressure or being exposed to low levels of blood pressure. But I think most of the concern there is with older adults. For younger individuals, I think the lowest your blood pressure is, the better off you are. And 130 over 80 would be what I would recommend. I would become worried if the blood pressure is above 140 over 90. That, I think, it's time to consult your general practitioner. But even before measuring the blood pressure, the advice would be to engage in physical activity. Doesn't have to be extreme. If you can be fit, great. And very importantly, be aware of what you eat.
Dr. João Lima, thank you so much for talking with us on the People's Pharmacy today.
Thank you. This has been a pleasure.
You've been listening to Dr. João Lima, Professor of Medicine and Radiology and Director of Cardiovascular Imaging at the Johns Hopkins Hospital. His research was published in the Journal of the American College of Cardiology, and you'll find a link to it from our website.
Let's go right to the phones, 888-472-3366. Frank in Corning, New York. Welcome to the People's Pharmacy. What's this about meditation?
Yes, I found when I had high blood pressure and I was suspicious of the medicine. I wasn't sure exactly what it was doing. It was supposed to bring my blood pressure down. I decided to try meditation, and I found that between 10 and 20 minutes of relaxing, breathing deeply, and the other rules for meditation helped me a great deal, because I realized that I sometimes get anxious, and that's one factor, as the doctor indicated. And I'm 82 years old, so I'm using meditation periodically when I can feel a sensation that suggests high blood pressure. And my blood pressure ranged quite a bit, from 140 to 160, sometimes 170 over 89, 90, or even higher. And so it was significant that I could bring it down 20, sometimes 30 points.
Well, Frank, thank you so much for sharing that. You know, I know a lot of the health professionals who are listening to us are going, you can't feel your blood pressure going up.
Well, sometimes you can, but it's not reliable. So you shouldn't rely on the feeling to know that your blood pressure is high. You should use a home monitor. But using meditation when you can is a great idea. We like that, Frank.
Of course, losing weight and exercising also makes a difference. We go to Minu in Leesburg, Virginia. Welcome to the People's Pharmacy, Minu.
Hi, Joe and Terry. Thank you for taking my call. I'm just sharing my experience regarding choosing to be vegetarian for a long time and then became a vegan that supported my, blood pressure, overall health, everything relating to have enough energy to work, to think, to be more functional in life. I am over 68 years old, and my blood pressure, depending on, as you mentioned earlier, if there was pressure or under life circumstances you're experiencing a little more pressure in life, perhaps it goes up. But it's been steadily between 120 and recently is 112 over 59.
Well, Minu, it sounds like that is a great accomplishment. And so you have now passed along to everyone else the possibility that a vegan diet might help lower the blood pressure. Joe, we have an email from Elliot Fix who says, studies show that just 4 stalks of celery a day can lower blood pressure. Ironically, celery is loaded with sodium.
Interesting. But, also that vegan diet that Minu is following, it turns out that, it's high in magnesium and it tends to be high in potassium, and both of those minerals tend to lower blood pressure. And also, of course, a lower risk of developing a cancer issue, because if you're a vegan, you're not eating any of that processed meat.
Absolutely. And Joe, the last couple of weeks, we have been discussing head injury and concussion. So we were quite interested in the news that U.S. Soccer will no longer permit young players, those under 10, to head the ball at all, and those between the ages of 11 and 13 are not allowed to head it, or are limited to head it during practice.
And, I know that there are a lot of people who are going to go a little crazy about that and say, oh, heading is such a part of soccer. But in point of fact, there are some pretty powerful forces that are transmitted, especially if kids bump their heads when they go up to head the ball.
Oh, bump with somebody else, yeah.
Exactly. And so concussions make a huge difference, and that's what we've been talking about on the People's Pharmacy for the last couple of weeks. I have to say, I celebrate this decision by U.S. Soccer to limit that risk. Well, I have to say that's just about all the time we have. Thank you so much for listening to the People's Pharmacy. Thank you for sharing your thoughts about vegetarianism, about multiple medicines.
And meditation instead of medication.
Yes,
or
indeed.
In addition to.
And please do follow Dr. David Kroll's recommendation to let your doctor know everything you're taking. And that includes not just medications that are prescription. It also includes over-the-counter drugs. It includes dietary supplements, herbs, you name it. Your healthcare providers need to know what you're taking in order to check for drug interactions. We don't want any deaths because of polypharmacy.
Lynn Siegel produced today's show. Sophie Copeland provided technical assistance. Al Wadarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Redex Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number's 800-345-7339. The website is uttercream.com.
If you'd like to buy a CD of today's show, you can call 800-732-2334. Today's show is number 1013. That number again, 800-732-2334. Or you can place the order online at peoplespharmacy.com. At the site, you can tell us what you think about the show or find information on prescription drugs, herbs, and home remedies.
You can also subscribe to the free podcast of our show or our free email newsletter. It's all there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Be sure to join us next week when we talk with Dr. Andrew Weil about his new cookbook and eating program, Fast Food, Good Food.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
This is an ad by BetterHelp. BetterHelp recently surveyed over 16,000 people and found that while 75% of people believe it's wise to seek support, only 27% of Americans are in therapy, and people stay silent to avoid being judged. BetterHelp has over 10 years of experience matching you with the right therapist. Because we're all better with help. Visit BetterHelp.com/StopTheStigma for their first ever State of Stigma report, the latest in mental health research.